What's going on, everybody? The theme of today is entry points for an initial evaluation. After we go through the conversational part or that more subjective aspect of the initial evaluation, we dive into assessment, right? The physical assessment part. Typically, people are going to make one of two mistakes. They're either going to start way too low level, and they're potentially going to put themselves in a situation where the eval then gets drawn out. It takes a significant amount of time because we're unable to gauge where we really need to spend a majority of that assessment time. Or we come in way too hot out of the gates. We enter and we do things that are way too challenging that potentially flare an individual up. Both are not necessarily ideal. What are some general recommendations in terms of deciding where to first start and then where to go from there depending on the patient presentation?
I like how you framed it up that when we get to the objective data or that assessment component, we often either start too early and we have too drawn out and we run out of time, or we're on that other end where we jump the gates and we put them in a situation that may be unsafe or may be provocative, or we're working with information we don't even know what to do yet because we haven't gotten some of that foundational information. I think the biggest thing we need to step back and appreciate is after we finish the subjective part of the eval, we should have a very good idea as to what's going on. When we get to the objective part or the assessment part of the evaluation, we should already have a really good idea what's going on. We should have a working diagnosis or at least a pretty strong hypothesis in our head that we don't go into the objective part trying to figure out what's wrong with them. We're going into the objective part to confirm our suspicions, rule out what we may need to differentiate from a diagnostic standpoint. But then, like you've alluded to, it's really to figure out what are they capable of doing from a capacity standpoint, competency standpoint, and a tolerance standpoint. So typically, I think the easiest way to enter this part is get them out of the chair, get them up on their feet, and have them do some activities that I would consider to be basic activities of daily living or just general movement archetypes such as squatting, hinging, pushing, pulling. And that doesn't mean with weight. That can just be going through motions with their arms. But things that are multi-joint, things that are often what we would consider in the weight room as like a compound movement. They're not overly complex in nature, so I'm thinking of like a toe touch, reaching up and back as far as we can go. How far can we rotate side to side? Can we squat? Can we balance on one foot? Can we get into a weight-bearing position with our hands, whether it's at the table or in a high plank or a front plank or a quadruped position? So things that are really just giving you a gross assessment of what people can do from a movement standpoint. If you were almost to categorize this as like, I think it was almost like an active warm-up that we're doing with somebody scaled to whatever their age and injury is. That gives you a very good idea as a whole what they're capable of doing, how quickly can they transition to and from these motions. It also gives you an idea of what's the theme or the route that this eval is going to take, meaning if I ask somebody to touch their toes and to lean backwards and it takes 3 minutes to get that done because the individual's asking multiple questions about where should my feet be, should I go as far as I can, what do I do if it hurts, it gives you an idea of the personality that you're working with. And is this somebody who needs more information or would benefit from having less information in regards to the direction and the instruction that you're asking them to do? But when you get through this initial section, now you know, all right, is this somebody that is relatively limited from a movement standpoint or is highly irritable? If so, maybe we need to direct them to the table for the next part of the session. And we need to just get some more isolated range of motion, strength testing, maybe just some general palpation or joint assessment, because we have something going on that requires more attention at a lower level of intensity. Or maybe they are flying through everything that you're asking them to do on their feet. Their subjective history doesn't lend them to having any red flags that you need to rule out. A lot of the stuff that you would look at on the table, so maybe like hip or knee range of motion, you already have a really good sense of that by watching them do a squat or watching them do some of these other activities. So you know any information I would get on the table is really just superfluous at this point. It's not going to add anything to what I've already found. and we can start getting into either more functional tasks on the turf or higher level, higher complexity tasks on the turf or in the gym, or maybe not even higher intensity or complexity, but just more relevant and specific to what their complaints are with or to what the issue is at hand. And a general flow that I find myself and my students going through with evaluations is after we do the subjective part of the eval, we then ask the patient to stand up. We take them through this standing movement assessment at the table. After we get that information, we'll quickly hop onto the table just to check whatever we need to there. Then we make our way into the turf or into the weight room. And that tends to be our way just from an efficiency standpoint. We knock out all of our standing tasks. We knock out all of our table-oriented tasks, whether it's range of motion, strength, palpation, special testing, and then we get up onto our feet again, whether it's in the turf or in the gym. At that point, you should also be kind of triaging in your head where your intervention or home program development is going to be. And this is where after you finish up on the turf or in the gym, assuming you've made it that far with the patient, maybe you're already in the area where you're going to be showing them the stretch, or you're going to be showing them the strength training drill, or whatever entry point intervention is. And I think it creates a very natural flow within the session for the patient of, we had some conversation in the beginning, we did our movement assessment. During that assessment, we did all of our things standing, all of our things lying down. Then we progressed back onto our feet as opposed to hopping on the table, off of it, going to the turf, coming back to the table. And it seems to be very well received by the patient because it looks organized, it looks structured, and it looks extremely thorough as well.